Thanks for being here, everybody. Welcome to the webinar. My name is Serena. I'm on the marketing team here at Uqora. For those who are new to Uqora, welcome. We specialize in UTI education, UTI relief products, and proactive urinary tract health supplements. Today is the first day of November, so this marks the first day of Bladder Health Month. And today we also start our countdown to National UTI Awareness Day. National UTI Awareness Day is observed every year on November 21st and was actually created by Uqora in 2020. So this is our first webinar of our expert-led webinar series this year, and we really hope that you learn a lot today. We wanted to go over a couple of logistics before we get started. This webinar will be about 45 minutes long, and it will be recorded and posted to our YouTube channel for later viewing. As attendees, you can use the chat feature to communicate with us, but don't worry, your audio and video will not be visible in our recording. We also wanted to thank you for pre-submitting your questions when you signed up for the webinar, because we actually carved out some time at the end to answer some of those questions for you. So without further ado, I'm so happy to introduce Uqora Medical Advisor and Urologist, Dr. Katherine Klos, who will be leading this webinar for us today.
Awesome. Well, Serena, thank you so much for having me. Everyone who's out there in the virtual world, thank you for having me. I would love your questions. We do have some that we pulled, but please feel free to insert them during the chat. I'm happy to answer along the way. This is, what I do every day, and as streamlined with the information I try to be. Goodness knows I'm probably forgetting something, or something that's second nature to me might not be obvious. So I'd love to answer your questions. I will not bore you, but I will give you a quick 2-minute spiel about myself. I am a DC-based urologist, and like we already talked about, thankfully it hasn't snowed here yet today, but I know my friends in Massachusetts got some snow thanks to the chat, and my folks in Chicago got some snow. So the weather change is upon us. I have been practicing for about almost longer than I would like to say, but like 12-ish years, and I see a ton of patients with recurrent UTIs. I also do sexual health. I do hormone replacement, thanks to kind of my introduction into recurrent UTIs, but that's really one of my favorite patient populations to treat. I love talking to patients, and it's so nice to be able to talk to a little bit of a larger group, because I think one of the things that patients come in when they see me is with a lack of knowledge. They've tried to self-educate themselves, and no fault of other physicians, but sometimes they don't get the attention that I think they deserve when they come in for urinary tract infections. And that's, some of the history can be, let's just give you an antibiotic and I'll see you in next time you're symptomatic. That is not my approach. So I'm so excited and thankful to work with a company like Uqora and try to advance other avenues for UTI prevention and treatment. So I'm in DC. I treat a lot of things. I have 3 small children who all went trick-or-treating last night. So this morning was a bit of a rough start for everybody, but hopefully this Zoom webinar won't be a rough start, and we'll fly into it. So here we go. Sound good? Okay, so you guys are all, those of you who have no science background are probably, quivering in that, why do we care about, the anatomy? And I know you do care, but it's important to understand the genitourinary anatomy before we get into urinary tract infections. Because what are urinary tract infections? Infection of your urinary tract. Well, if you don't know what the urinary tract is, then you're starting off behind the 8 ball. So I'll minimize this, I promise, but just to give you a broad overview, because if you do go in for an evaluation, it's important for you to know, why is the doctor doing that? Why are they recommending something with my kidney when I'm talking about my bladder? Okay, so start with the kidneys. That's where we start in the genitourinary system. The kidneys, through a very complex process, filter your blood and make urine. So urine is just liquid waste product. From the kidney, the urine quickly exits. The kidney is not a storage location for the urine. It's where the blood is filtered. Then the urine is supposed to, move quickly out of the kidney. It travels in your ureter, which is a very thin muscular tube. It's about 25 centimeters long from the kidney all the way down to the bladder. once the urine hits the bladder, this is the storage mechanism for your urine. Okay, so the bladder is designed to store urine. It is a muscular, it's a muscular hollow organ, and it's important to understand that the muscle wall is meant to relax, and that allows you to store urine within the bladder, and it's also meant to contract, which allows you to empty your urine. Now, the other important component is the urothelium, or the lining of the bladder. So that is not a muscle, it's the initial layer. And that acts in two ways. First, it is a barrier. So it prevents whatever's in your urine from seeping into your bladder. It's the same like the lining of your mouth. The coffee that I've been drinking all day and too late in the day is not getting into my cheeks because there's a barrier there. The same thing is happening with the lining of the bladder. We could talk more about breakdown and bladder lining at another time, but that's its main one of its main jobs. Its other job is it's the first responder to a stimuli. So think bacterial infection. So the urothelium is actually the first responder to that. Just important to denote there's two structures within the bladder. And then the urethra, this comes into play in infections, and I'll talk about this later, is again, another muscular tube. It's about 3 to 4 centimeters in length. It allows the urine to exit the body at rest. So doing nothing, your sphincter, your urethral sphincter muscles are contracted or tightened to hold the urine in, okay? And then when you go to urinate, we'll talk about that in a second, what happens. But that's kind of the basics of the internal anatomy. Externally, again, just to get you oriented, this comes into play when we talk about risk factors for infection. Clitoris is obviously there, your female sex organ, labia. We don't have a lot of great data on what your labia do. We know that the labia minora are only evident during, or not only evident, become evident during puberty. You always have labia majora. We don't have a lot of information on them. We do think that there's some barrier, their function as a barrier. So I don't want to overpromise things. The urethral meatus is the external portion of the urethra. So that's what you can see potentially when you're doing a vulvar exam. The location of the urethra is important. In some cases, if it's more retracted or pulled back into the vaginal canal, it can increase your risk of infection. You've got the vaginal introitus. I'll talk a lot about the vagina and the vaginal microbiota. And then the perineal body doesn't have anything to do with infection, but it's a really important structure within your pelvic floor. So this is a location where 9 different muscle groups attach. Okay, it's a fascial layer that they all coalesce. And in some instances where you have recurrent infection and can unfortunately develop more of a muscular pelvic floor dysfunction, this is one of the areas that can be impacted. So while that has absolutely nothing to do with infection, it does come into play in your pelvic floor and can be a spot where patients have problems if they have recurrent infection. But that's kind of enough on there. All right, what do we got next? So this I put in probably just to remind myself that I had to learn this during med school, and I still use it today. One of those things that I wish I didn't know, but I do. Your metrition reflex is a really fancy word for saying urination. I don't put this on here to overwhelm you, but to help you understand that it's a very complex process. And again, when I was talking about at rest, your sphincter muscles are contracted. And what is happening is your bladder muscles are relaxed. When your bladder fills to capacity, what is capacity? It's about 300 to 400 cc's. So think like a can of LaCroix. When it reaches capacity, there are these stretch fibers within the bladder muscle wall. They help signal your brain through this complex nerve process to say, I've got to go to the bathroom. Your brain gives you, the time and the social appropriate cues to find a bathroom. And when you go to empty your bladder, again, you have to have proper voiding to, again, ensure you have a healthy urinary tract system. The bladder muscle contracts and the urethral sphincter relax to allow the urine to empty the body. So that is proper voiding. That's what we want to foster at all stages in our life. But again, that's in and of itself can come into play in infections, but just nice background information, in my opinion. So what we're here to talk about is urinary tract infections. This slide, again, I don't love reading off of a slide, but I want you to know the information. So I probably put more information on here than I would normally if I was just talking to someone one-on-one. 150 million people a year are affected with urinary tract infections. I mean, that is a lot. Most common bacterial infection, and 50% of women will experience at least one UTI by age 35. 20% between the ages of 18 and 24 will have one annually. I mean, that is a lot. So not only is that a lot, worldwide, age range, but when we talk about healthcare burden, it's a significant number. All right. Almost 1.5, over $1.5 billion annually allocated for the treatment of urinary tract infections, which is why it's amazing that you are all on here trying to be proactive about your health, not only for yourself, but for the overall burden of healthcare, which I think all could agree needs to change dramatically. Nothing on here is anything you can't find on your own with a quick Google search, but I think it's really highlights the need for us to talk about urinary tract infections and not diminish them as just, you have one, here's an antibiotic, go on your way. So that is my plug for, being a better healthcare provider. So what is a urinary tract infection? I think this is one of the most important things to understand, because frequently I see patients and they'll say to me, I don't know if I had a urinary tract infection or I did have one. And some of the time I can't answer that for them. But the reason that we can't is because what a urinary tract infection is it's an inflammatory response to, some irritant. In the case of infection, it's bacterial as the irritant. So the bacteria initiates an inflammatory response. Now, an inflammatory response can be initiated by other things, but it is the same inflammatory response. Your body doesn't say, I've got this inflammatory response for bacteria and this inflammatory response for something in your urine or a change in the bladder lining. You get the same response. So you need to understand that you're validated in the fact that you don't always know. I don't always know. Okay. So it is important to go through testing, but that is the definition of a urinary tract infection, an inflammatory response to a bacterial pathogen. Symptoms vary from patient to patient: painful urination, frequency, urgency, bladder pain. Some women will get an increase in incontinence. Some women will get, and men, shouldn't discount them. Some folks will get bleeding. Everyone can have a different presentation. A UTI is always not the same symptoms from one UTI to the next. So I wouldn't rely on symptoms as a way to say, oh, I have a UTI or I don't. Last time I had it, I had burning with urination. This time I'm just going to the bathroom more frequently. It's really important to seek evaluation when you have any change in your baseline urinary pattern. Obviously, if you're concerned also about an infection. The remainder of this, what we're going to talk about is what we call an uncomplicated urinary tract infection. So the remainder of my slides are going to reference someone who has a normal anatomy. So we already know what that is because I bored you with that, and a no immunocompromisation. So everything thus forward is just gonna be on the uncomplicated UTI. So what is cause a UTI? So UTI is from fecal bacteria. All right. And most of the time I say that, patients, are like, that's disgusting. And I will be the person to tell you, unless you're that very rare percentage, it is not related to your hygiene habits. Okay. Most of us are taught appropriate hygiene habits. Yes, it's good to review it, but I don't like it. I can't imagine how, you guys feel as the patient when you go in and someone says, well, are you wiping back to front? And you're like, am I wiping back to front? I've had 6 UTIs this year and I've tried 4 supplements and I've been on 2 antibiotics. I don't think, again, it gives the topic the necessary value that it should have. But it doesn't mean, and I'll talk about the reasons that, you might be plagued with it versus someone else. But it doesn't have to do with your, again, 99% doesn't have to do with hygiene practices, but it is caused from fecal bacteria. The most common pathogen in premenopausal women is E. coli. It represents 6% of infections. So a lot of what I'll reference in a lot of the literature is specifically dedicated toward E. coli because of that. Some of the other more common ones, especially if you're someone who gets a culture or PCR, Klebsiella, Proteus, Enterococcus, staph does also cause UTIs. So staph is a bacteria that can be very common on your skin, but it can also be a UTI pathogen. So it's just not something to completely ignore. What do we got next? Okay, so what is a recurrent UTI? Most of us are here because we haven't just had one UTI. Recurrent UTI is 2 or more in a 6-month period or 3 infections per year. The data is that about 25 to 50% of women who have one UTI will have a second UTI within a 6-month period. So that's a significant number. Some of that has to do, we don't have to go too far off, some of that has to do with the effects of antibiotics on the vaginal microbiota. Other of it is, predisposition. Some of it is you didn't, weren't able to rid the infection the first time. But you need to keep those things in mind. And if you've had a UTI that's been treated and, it's a few weeks later and you're like, gosh, I feel like my symptoms haven't gone away, it's not necessarily something that you should ignore. Okay. It could be, again, you could be one of these patients who have a repeat infection in that short period of time. Great. Okay. So this is my favorite slide. UTI risk factors. So maybe not your favorite slide because there's nothing that at this juncture we can do about genetics, but it is not your fault. Okay. So that is one of the things that I tell my patients all of the time. You getting a UTI is not your fault, no matter what you think you did or didn't do. We have good data to show that there are specific things that can predispose a patient to urinary tract infections. So one of the things that we can identify in blood groups is what's called a secretor or a non-secretor. There is not a test for this. So I know I always say that to patients and they're like, can you test me if you're a secretor? And that's not something that I traditionally do because I'm not going to change anything. Okay. But non-secretors have been shown to have enhanced adherence for E. coli. The thought is they have more binding sites for E. coli, and that's one of the reasons they have more enhancement because there's more places for things to attach. There's also a notion that certain genetic groups have, it's on here, an immune hyporesponsiveness, meaning you don't respond the same way to E. coli as you may to another pathogen. And that is just part of your genetic makeup. It has nothing to do with, what lubricant you used or whether or not you used, a spermicide. You're just not mounting the attack against that bacteria as maybe one of your peers. So these are 2 kind of well-established genetic factors that we have that contribute to UTIs. And I would imagine in the future, we will learn more, but I want to give you the ones that have the most data. So I start with that. There are things that are just from a cellular level, and we'll talk about the other, anatomical, but from a cellular level that are predisposing you to a urinary tract infection. Right. So this also is predisposing you to a urinary tract infection, unfortunately. And this is the other component of genetics that is more macro versus micro on the immunoresponsiveness. So first, we talked about the anatomy. Again, that's why I started with it. Boring but necessary. The female urethra is 3 to 4 centimeters in length. The male urethra, you're talking about over 20 centimeters in length. So you don't have that barrier from the external bacteria to the bladder, okay? Not only that, is the area around the urethra, it's not just skin. So surrounding the male urethral meatus is just skin. Surrounding the female urethral meatus is the vagina. And we'll talk about a lot of the vaginal microbiota. But so that is a predisposing factor. You have a short length of the urethra, and the tissue surrounding the urethra is different. Okay. Now, the location of the urethra is also something to be notable. One is that, especially in the postmenopausal patient, but in some, just in some women in general, some women on birth control pill, you can get retraction or kind of the urethra kind of pulls back into the vaginal canal. And obviously, if it's closer into the vaginal canal, the more likely there's going to be for bacteria to get into the meatus. Secondarily, and we'll talk about this a little bit later when we talk about hormones, what happens in a low estrogen state is you get a more pronounced urethral meatus. And that in and of itself, when it's more open, is going to allow for entrance of the bacteria. Also, one of the things that my realtor friends will say is location, location, location. The urethra, again, is located adjacent to the vagina and in very close proximity to the rectum. You're talking probably 8 to 10 centimeters from the rectum to the urethral meatus. So we've got, the actual meatus itself, is it open, the length, the positioning, and just in general, the close proximity to everything. Okay, so vaginal microbiota. This is one of my favorite. One of the things I like the most. So like I said, all UTIs are from fecal bacteria, but they typically don't directly go from your rectum to the meatus. What happens is they go from the rectum and they reside in the vagina. And the vagina microbiota is very complex. We probably don't know everything that we will know in 10 years about it, but it's not uncommon if you do a swab of the vagina to find some Enterococcus, some E. coli, maybe in really low amounts, okay? And that's close to proximity. But what we want is the predominance of these lactobacillus groups here. So there is data to show lactobacillus crispatus, ginsengii, and gasseri have been associated with a healthy vagina. Why is this? Well, these microorganisms, a few reasons. One, can competitively bind against where E. coli is going to adhere on the vaginal, in the vaginal mucosa. So it's actually a barrier or a blockade. They also produce hydrogen peroxide, which is a weak acid and helps keep the environment more favorable for your lactobacillus species and less favorable for pathogenic bacteria. And again, we want lactobacillus in total to comprise, about 80 to 90% of the vaginal microbiota. So again, these strains and specifically have been associated with a kind of a healthy vagina. We want these strains to be in about 80, 90% dominance within the vagina. And that fits with what I said in the beginning. It's not uncommon to have some other, bacteria within the vaginal canal, but you want this bacteria to predominate. I will talk about it a little bit more. Oh, hang on one second. In that the lactobacillus predominance changes with a change in estrogen level, and estrogen levels dramatically decline and essentially bottom out to 0 in a postmenopausal patient. It can be affected by birth control, and in some women, their menstrual cycle is such that those lower dips in estrogen can cause fluctuation within your vaginal pH and subsequently your vaginal microbiota. So keep going. Let's stop that. All right, so sexual activity, unfortunately, friends, all the good things come with complications. Anything that's going to increase the proximity of bacteria to your urethra is going to increase your risk factor or incidence of urinary tract infections. So I hate to say that, it's such a fun thing with potential negative side effects, but it's, it is what it is. Doesn't mean it's the end of the world. And this is where I talk about UTIs are multifactorial. So many people are having sex or masturbating or having oral sex or your version of that, yet they're not getting urinary tract infections. So you've got to understand, if it were the case that it was one-to-one, everyone would be getting it. So that's why you've got to think about the other layers and, what things can you control or help promote a good environment for prevention. Specifically, spermicides have been associated with staph and E. coli infections, and then lubricants, they can have, and the spermicides also are the reason that they're associated with infections is because they have toxic effects on the microbiota of the vagina. And again, not everything, but a lot of things come back to the vaginal microbiota. The lubricants contain different preservatives. They can effectively, essentially inhibit lactobacillus growth. So again, back to the vaginal microbiota, it's super important. in maintaining a healthy vagina. And again, you want to create good bacteria so it's there to prevent the pathogenic bacteria from being able to reside in the vagina. Hydration. This is great. It's wonderful. Most patients come in, to see me already knowledgeable about increased water intake. I'll talk a little bit towards the end about some other fluid intake and how that may affect your bladder, but it is well documented, and it's one of our guideline recommendations that water intake over 1.5 liters a day is helpful in prevention of urinary tract infections. Why? Dilutes the urine. There's less there for the bacteria to use as fuel to grow, and it promotes good voiding patterns. So if you're going to the bathroom more frequently, you're flushing out any little bit of bacteria. So that's great in terms of your overall health and for prevention. All right, this one, I throw this in here. It's some questions I get asked, and there is an increased risk of urinary tract infections, some in certain times of the year. Holidays are actually the highest, probably due to increase in sexual activity, because the month with the most birth is August. But other things that can impact it can be temperature related. So swimming, hot tubs, baths can be affected. When talking about pools, chlorine level. Chlorine can impact your skin, again, your vaginal microbiota. Hot tubs can lead to Pseudomonas bacteria, not only in UTIs and vaginally, but on your skin. And then, unfortunately, lakes, oceans, all of that wonderful nature does contain fecal material. And again, I know so many people do it and don't have a problem, but if you're somebody who struggles with UTIs, I don't want you to be wildly restrictive, but it is important to note what might put you at risk. Okay, so this one I could talk about for 1,000 hours. Oh, hormones. So estrogen is essential for maintaining a healthy vaginal microbiota, okay? And it allows the vaginal pH to be low. Women are affected differently. So I see women who, so your estrogen levels, so again, back to the basics, when your day one of your menstrual cycle, so the few days before and the few days after, your estrogen levels are the lowest in your cycle. So estrogen levels, they're anywhere from 30 to 50. And then they rise, and then when you release a follicle, estrogen levels start to decline until they're at the point where you start menstruating again. So in a menstrual cycle, the first few days before your period and if your first few days after, your estrogen levels are the lowest. Some women will find that they can have transient BV, yeast infections, incontinence, prolapse in this low estrogen state. But what can also happen is you can get a transient change in your vaginal microbiota, and that might be enough to predispose you to an infection. And the postmenopausal state, we don't even have that, we don't have any cadence, and we don't have that, low level of 30 to 50. You have an estrogen level of 0 or 5. And it drastically changes your the composition of your vagina. You go back to having skin bacteria in there and other pathogenic bacteria. First line recommendation for treatment of urinary tract infections in the postmenopausal woman is vaginal estrogen, and that's because one, it can impact really impact your vaginal microbiota. It does a lot of other things. It is anti-inflammatory. Estrogen has been shown to have anti-inflammatory properties. It's been shown to interfere with bacterial adherence. It promotes, blood flow and increased tissue quality to the vaginal tissue in the surrounding area. That tissue is all hormonally sensitive. So your urethra, your vagina, your vestibular area, your clitoris, all hormonally sensitive. I'm trying to keep it mindful of time. So I think we're getting close. So estrogen is super important, even if you're not in the postmenopausal state. All right. And again, it helps with tissue quality and regulation of microbiota, and competitively will help block with bacteria. Okay. So other things, I'm not going to go too far into this because again, we're talking about the uncomplicated patient, but any overall systemic whole body disease, more specifically diabetes, can impact or increase your risk for urinary tract infection. Voiding dysfunction, what does that mean? For men and women, it can mean different things. It can mean, let's say you're holding your urine for too long and you're accumulating a lot of urine within your bladder. Any little bit of bacteria that's in there can percolate and grow to a larger degree than it would if you were going at a more regular cadence. Okay, incontinence can also impact your risk factors for urinary tract infection, as it can alter, the skin externally. It leads to moisture around your urethra. So two short examples. GI changes, I do think this is important, and I really hope we have more information on the correlation with your gut and urinary tract infections in the future. But because infections arise from gut flora, the healthier your gut, in my opinion, it should equate to hopefully a healthier vaginal microbiota and potentially less risk factors for UTIs. There is nothing out there on that. You're probably always going to have, some component of bacteria within your gut. So I'm not saying get rid of it by any means, but diarrhea, constipation, those can be risk factors as well for urinary tract infections. Okay, so this I helped generate because I'll tell you, common things come in. It doesn't mean that these are going to be your questions, but because I see so many patients with recurrent UTIs, this is, kind of a theme in what's out there. So what is a urine culture? All right. So urine culture is the mainstay for diagnosing a UTI. Do I think it should be? Maybe not. But essentially what happens is you have a urine sample, and that urine sample is then placed on what's called an agar, which is just a culture plate. It's that lovely little guy, the other picture. And the bacteria is put in a growth environment, and it's monitored to see, is there growth of bacteria? So you take the urine sample, you put it on this nutrient-rich environment, and you watch for any growth. That has been the traditional way to diagnose urinary tract infection. The amount of bacteria required to define as a urinary tract infection is greater than 10 to the 5th colony-forming units per high-power field. Oh, sorry, per milliliter, excuse me. So that is the traditional way. That data is over 60 years old. It's not my favorite way that they chose the number of colony forming units to diagnose a culture, but I'll kind of limit that. Are they required? So technically they are not required in an uncomplicated patient for treatment. All right. Based on what I see, I always like to get a culture because you can ensure that way that you've got a bacteria and you're not confusing potentially a bacteria with another source of inflammation. All right. But are they always accurate? No. And that's what gets into this next question. What is a PCR? So a PCR is it's a molecular way to detect DNA or RNA from bacteria. Okay. It is more sensitive than a urine culture. It's faster. You can get the results sometimes as quickly as it takes to run the assay, sometimes 4 hours, sometimes 6 hours, versus a urine culture, which can take, 48 hours to assess growth. All right. So a culture is not the same as a PCR. Typically, PCRs will be more sensitive. And why is this important? So there is data to show that women who have less than 10 to the third, so I know all of these numbers, colony forming units of bacteria, which a lot of labs don't report, okay, will have symptoms. And then you go to have a culture, and the culture is negative. And you're like, did I have an infection? Did I not have an infection? Well, there's data to show that you definitely could have an infection, but we're relying on a testing mechanism that may not be the most accurate. So is a PCR always necessary? No, but in some instances, it can be really helpful, especially in someone with recurrent infections, because you can mount symptoms at a much lower colony count, okay? And usually what happens if you've had recurrent infections, you have symptoms and you're like, I'm going to pump myself with water. I'm going to take all of the supplements. And then you go to give a urine sample and you have this wildly dilute urine sample. That's not going to grow anything. And you're waiting 3 days for something. Not the worst things ever, but That's one of the advantages of PCRs. You can get a faster result and you get bacteria that you may not detect on a culture that could be the cause for your symptoms. I say all that. The downside of PCR is it's hypersensitive. Okay, so it's going to detect all of those little bits of bacteria in there that we may not need to detect or need to treat. So it's really important to have a clinical interpretation of a patient's symptoms and history when you're looking at results of both a culture and both a PCR. But again, a culture takes time. It's growth of bacteria. It does give you specific antibiotics that are appropriate for use. A PCR is faster, it's more expensive, it's going to give you more sensitivity in any bacteria that is there. It does not give you the best antibiotic in terms of use, but there are different instances where they might be appropriate, different patient populations that one would be better for the other. Last thing I'm going to say about this, so we can get on to some of the other questions, but one of the things that will come up is contamination, all right? And if you do a, front to back wipe, midstream urine sample, you should have, I mean, the literature is less than 1%, but let's call it less than 5% contamination, okay? And sometimes that's difficult on urine cultures because if they get more than one bacteria, they'll report, likely contamination. And you're like, I still feel terrible. The PCR allows us to say, oh my gosh, you have E. coli and Enterococcus, and maybe some staph that could definitely all be symptomatic. So that's another one of the reasons I like the PCR. Again, cultures are great too. It's important to know the difference, and it's important to know why they're different. So that way you can best go into, your doctor's office armed with, I think this, or I don't think this, or there's data on this. So hopefully that's helpful because that's one of the questions I get asked a lot. Oh, good. Antibiotics. I love this one. So despite being a urologist and treating a lot of patients with antibiotics, I don't love antibiotics. Again, one of the reasons I'm so excited to partner with Uqora, because anything we can do from a preventative standpoint and from a non-antibiotic standpoint, that's with, safe, I think is wonderful. So antibiotics, what do? They fight infection, all right? They target specific functions within bacteria to either, kill the bacteria or stop its growth. Different antibiotics work in different ways. Some disrupt the cell wall, some interfere with protein synthesis, some interfere with DNA transcription. There's different ways, and again, I'll leave that out. Different ways that antibiotics work, but that's what they're doing. They're either killing the bacteria or inhibiting their growth. All right. What antibiotics should we use? Oh my gosh, I wish I had like $1 for every time a doctor called me and said, so-and-so has a UTI, what should I use? And there are a few things. There are guideline recommendations for first-line therapy for patients with infections. But that's why the advantage of doing testing is with a culture, it will tell you the specific antibiotic that you can use that's effective. For a PCR, there's some guidance based on what type of bacteria it is as to which antibiotics may be most appropriate for usage. So the downside of antibiotics and why I don't love them is that they kill everything. Okay, so they kill all of your vaginal flora. They disrupt your gut flora. And this, in my opinion, is one of the reasons that we get this 25 to 50% recurrence of infection within the 6-month period, because not only are you treating, your UTI, which is great, but you're also, killing all the good bacteria that's around that could help prevent another one. So I'll stop there. Oh, biofilm. All right. So as a urologist who didn't, let's say I didn't treat recurrent urinary tract infections, we're still familiar with biofilm. Okay. So what is biofilm? I always do this when I'm talking about biofilm. So it's a complex structure. It contains microorganisms and what we call extracellular matrix proteins and bacteria that kind of are all woven together. They can adhere to body tissue and foreign tissue. So as urologists, you learn about them. Again, let's pretend I'm not treating recurrent urinary tract infections as adhering to a catheter or adhering to a stent internally or a stone. All right. So that's the nice part is I bring this background of knowing about biofilm or having some conceptualization of it from other areas into my recurrent UTI practice. So That's what biofilms are. How do they relate to urinary tract infections? And this is a very, developing research topic. A lot is being done in the lab, not as much as being done in practice, but I think that's, obviously going through some changes. What can happen, and I believe this, is you can get bacteria on the lining of the bladder. So you don't have a catheter, you don't have a stone, but you can get bacterial biofilm adherence to the lining of the bladder that holds onto the bacteria. So you're like, great, that's wonderful. Can you test for it? Not yet. All right. The downside is you don't get good antibiotic penetrance to the bacteria in there. So you get an infection, and yes, maybe you feel better. And so for patients who are a little more complicated and have precipitous recurrence, this is one of the things you need to consider is there a biofilm there that can be resistant to not only your immune response, but is this resistant, to antimicrobial agents? Is that helpful? Hopefully. Okay.
So helpful. Everything that you have to share is so helpful.
I thought it was going to be quick, and I was trying, and I talked fast anyway, but I'll try to motor through this next part.
So we do have a couple of questions from things
Okay, great.
people submitted, and these were trends in all of your questions. So we tried to cover everything.
Okay.
The first question that we have is, I have my first appointment with a urologist in a couple of weeks. What information should people have ready to share with their urologist at their first appointment?
That is great. So I think it's, okay, if I had like the perfect patient who's going to come in, one, be open-minded. Okay. So it's good to have your information, but it's also nice to think, all right, I'm going to give them my information and ingest some of it, but have your goals in mind. Top 3 goals. Like, what do you want to get out of this visit? And it's totally fine to say that at the beginning. I mean, if ideal scenario, someone would come in and would say, I want to know why I'm getting a UTI. I want to know what to do to prevent it. And I want to know, are my kidneys going to be affected? Like, come in with your top 3 questions. They don't have to be those. You should also, if possible, have all of your background culture information, because that is one of the most important things. If you have previous labs, whether they're just a urine dip that was done at the urgent care, or an ultrasound that was done on your kidneys, or a culture report or a PCR, having that data available will help not reinvent the wheel. Our healthcare costs are already so high, especially around UTIs, but anything that we can do to streamline care by having a trend or additional information is super helpful. So that's what I would say. Open-mindedness, have your top 3 goals or questions that you want to have answered, and then any historical labs or imaging that you can bring to the table.
Cool. Good to know. Another question that we have is, do carbonated drinks and caffeine contribute to UTIs?
Right. So I love this question. People always ask me, does diet cause a UTI? And the short answer is no. There's no diet that's going to give you a UTI. But the long answer is, so when back to my anatomy basics, so the urothelium, or the lining of the bladder, that is designed to be a barrier, that can become irritated. So I always use my skin as an example. So if I scratch, what's going to happen to my skin? It's going to turn red. Why does it turn red? So the capillaries on the surface of my skin are dilating. That's what's giving it the right color. Same thing can happen in the bladder. I don't have a way to tell you which is, going to be irritated, but we do know that for a lot of people, carbonation, spicy foods, caffeine, alcohol can be irritative to the bladder lining. What happens then? Blood vessels on the surface dilate. It's just another entry point for bacteria. So that's not going to give you a UTI. 1, it can give you inflammation, which sometimes can mimic UTI symptoms, but 2, it can increase capillary penetrance.
Interesting. I love that analogy of scratching. That's a really great way to put it. Okay. Are there any precautions that females who are sexually active with other females can take to prioritize their urinary health?
So I think this is universal, but the biggest thing would be a healthy vaginal microbiota. The nice part is you're not, if you're a female with another female partner, you're not worrying about spermicide, so you can put that off the table. Some women, will have different reactions to lubricants. Trying to use a preservative-free lubricant is best. But the biggest thing is, your vaginal microbiota or your vaginal health. which again is fairly universal. So nothing specific other than pay attention to your vaginal microbiota, pay attention to any changes that you might notice in your cycle, or with, exposure to, anybody, exposure to sex toys, exposure to dilators, etc.
Cool. We have 2 more questions that we're going to run through as fast as we can, but I know for males, how is prostate health and bladder health linked?
Oh, okay. So that is a loaded question, but not a terrible one. So I didn't put the male anatomy in here, but essentially the prostate gland functions to produce fluid that helps your sperm mature for fertilization. And the prostate gland sits below the bladder. So it sits like right here. The urine has to pass through the center of the prostate to evacuate. Now, there are a lot of things that can impact prostate health. Let's talk about size or bladder health. So size of the prostate, as men hit about 40, we don't know why, there's increased growth of the prostate, non-cancerous growth, just benign growth. That can affect the bladder's ability to empty. All right. So that's number one. You can get retention of urine. That retention of urine can precipitate urinary tract infections. It can also impact the bladder in that your bladder muscle, this is not infection related. The bladder muscle will hypertrophy or increase in size. So like pretend I went to the gym and I had like a really big bicep. It's because I'm going to the gym and working out. Same thing happens with your bladder muscle. Is it can increase in thickness because it's working so hard to squeeze out. In that increase in thickness, one, it can change the capacity. So sometimes it's not as big. And 2, it can cause uninhibited contractions in the bladder muscle. So you get more frequency and urgency. In terms of prostate health from a bacterial standpoint, 100% bacteria in the prostate, not always, but can get into your bladder and cause a urinary tract infection. So there's a lot of aspects of prostate health, but size and bacteria can definitely impact your bladder. So
Cool.
Cliff Notes version.
We could do a whole webinar on that.
You're too young to know what Cliff Notes are, but I promise it's a thing.
And our final question today is, are menopause or vaginal dryness triggers for UTIs?
Yes. Again, and I harped on this. I'm glad this is the last question because I feel like I've addressed it a bit, 100%, and it has to do with your estrogen. Well, the dryness maybe, but most vaginal dryness is secondary to lack of estrogen in the postmenopausal state. We know that you have 0 to 5 estrogen level that changes your vaginal rugae, it shortens the vaginal canal. It changes the blood flow. There's no collagen or elastin in the vagina. You don't get the lubrication. All of that affects the pH. pH in the postmenopausal woman is typically over 4.5. You want a vaginal pH of 4.5. Why is that? Because again, our lactobacillus that's producing the weak acid, hydrogen peroxide, will keep us in a good state. So a 100% postmenopausal women have an increased risk of UTI, and that has to do with lack of estrogen and tissue changes. Vaginal dryness, let's say it's in the premenopausal patient, is still usually hormone related, not always. But if you have it and it's not hormone related, a few things. One, you have breakdown of that tissue. So any breakdown of tissue can allow for more bacterial penetrance. 2, some of the things that you're using to try to an over-the-counter moisturizer or vaginal lubricant can in and of itself, then precipitate changes that would lead or put you at an increased risk for a urinary tract infection. So those are my short answers.
Yeah, thank you so much for answering those additional questions. I know we have even more questions, so we'll do another webinar soon for sure.
Great. Oh my God, thank you so much for having me.
Thank you.
It's been such a fun time. I hope everyone stays healthy. I think we've all had our challenges, and I hope all snow melts for those who have it.
Yes, thank you so much. And thank you so much for joining everyone who's online